Everybody, this is Jim Prussack from the Pain PT, and I'm really happy to bring with you today a guest here, which I want to do more of. And I have Charlie Merrill here, who's a fellow physical therapist or physiotherapist here. Charlie, how you doing?
Good. Thanks for hosting me, Jim. I'm really excited to be here chatting with you.
Absolutely. And Charlie, just like myself, we're both PTs, and we're chatting a little bit off air about how we're just like a small little bit of people in the PT world doing this work. And that's why I wanted to bring Charlie on, because he's doing similar work that I'm doing. And I think it's another voice that we need and another person, spreading this message. So Charlie, why don't you just maybe introduce the audience to yourself, who you are, how you bring us up to how you got into this world.
Sure. Yeah. Well, I'm a physical therapist by training, as you said, and I always say that I think we are some of the best clinicians to be able to do this work. I just was on a call with a client earlier and talking about like the extent to which we evaluate the body and how important that is like a foundational starting point to be able to explore things beyond the body, right? Is to sort of get clear on what's true about the body and what maybe what things are myths or things that we can let go of, so we can move forward with this more biopsychosocial model. We're freezing up a little bit. Are we okay on the connection here?
Yeah, it looks like a little bit. Let's keep going. We'll see if this works itself out. It
Okay.
might just be something with Zoom.
Okay, great. So the origin story. Well, I guess I have to go back like to when I was born. No, I'm just kidding. I got into be a physical therapist precisely because I loved working on the body. I love fixing the body, as we used to say, doing manual therapies, manipulation, needling. Like I was really lit up about that in the late 1990s, when I started my practice. And it turns out you can do a really great job doing that for a lot of people, right? Because the body is such a compelling thing to treat when people have pain. And we know that if people believe that's going to help, it often helps, at least temporarily. But, about halfway into my career, about 10 years into my career, I felt like I was doing that really well. And yet something was missing for a subset of people. And I could just tell, I could feel it. And I'd had my own back injury when I was like early 20s, herniated disc, like all the signs of a herniated disc, numbness, tingling, really reproducible, loss of reflex, atrophy. And one doctor recommended surgery, and another doctor with whom I'd had a second opinion said, look, you're young, you're already feeling better. Why don't you give it some time? There's no danger. And that's what I did. And as I was working as an assistant in a physical therapy clinic among some great clinicians that were really helpful to me, I read John Sarno's book, Healing Back Pain.
When was
And
that? What year was that? Do you remember when that was?
that must have been like 1997, somewhere in there. This is before physical therapy school.
Yeah. Well,
And,
okay. Wow. Yeah. You
and
got to
I,
Sonora even before I did. I think I got them in about 2000, 2001. Yeah.
yes, I mean, not that this is a competition, Jim, but
Charlie's more
um,
well versed than I am. He got the Sarno early when he was in his, but that's
no,
awesome. Even before PT school, were onto some of this.
yeah, but I guess I would say, even though it took 4 to 6 months for my herniated disc, which was pretty big, and it right side correlated with my symptoms. And what I didn't know at the time was, 6 months later, why did I get better? Like, what happened to that disc? It was huge. It was on MRI. Like, where'd it go? And of course, now we know the discs heal themselves. And I kind of wish I'd known that, but I didn't have the option to do injections. I didn't really want to do surgery. I was young. And so I just felt really lucky that I got sort of what we would call the book cure, right? Like it made so much sense to me based on where I was in my life. But it was very personal. And so when I got into my career, I wasn't like, let's go John Sarno, right? I was like, let's get back to doing the good work of fixing people with our hands.
Mm-hmm.
And so 10 years in, I was like, something's missing. What's the next logical step? Treating pain, right? As a physical therapist, as a manual therapist. And right away, I was like, I wonder if anybody's teaching what John Sarno sort of said very directly and abruptly, and maybe not with a lot of strategies, except for to fire everyone on your team, right? I wonder if someone's like taken that and like expanded it clinically. And so I reached out and through the, I guess, the TMS community, I got connected with Dr. Schubiner, Howard Schubiner, and that was like the best person in the world, right, to connect with right off the bat. And
Yeah.
then this amazing, you know, this like community of people that I kept meeting, including you, Jim, like on that journey, um, has just grown and grown, and it's life changing. I mean, not just for me as a clinician, but for the people that I work with, as you know.
Yeah. Yeah. No, it's absolutely life changing. And, you know, let's give a shout out to Howard Schubiner, Dr. Schubiner, because he's been instrumental, I know, to you, but also to me. And he was one of the first people on my journey when I would got through and learned the stuff. And I was in Australia doing a physiotherapy training there, and Perth. And so I came back with some pain science, chronic pain, and I found Sarno. Led me, long story short, to Schubiner, and I ended up going to Detroit a couple of times and seeing him. I remember the first time being there, going into the hospital with him. It was just amazing to see how he worked with patients, and I was just blown away. So,
Well, I don't know if you remember this, but at first, you know, I took his course with Alan Gordon once, and it landed, but it was like 50% of it landed. And then I did it again a year later, and I was like, oh, I got even more. But it's been quite a journey to fully embrace the model and and use it to its, like, I don't know, to make it as powerful as it can be. Like, it took me a while to unlearn a lot of the stuff that I learned in school and to trust that I could bring more of these psychological and social strategies into my practice as a body trained clinician. I don't know if you felt that way.
I feel exactly the same way. And I always tell people, look, if I can unlearn this as a physical therapist who've been teaching this stuff for 20 plus years, then you can certainly unlearn it too, you know? So
Totally. Totally.
yeah, and powerful. So yeah, so you got into this work, and then you started working with Dr. Schubiner and teaching, right? Teaching some of this material. To maybe share a little bit about that and that side of things.
Yeah, I think I was so inspired. Like, there were a few points in my career. One was like learning how to trigger point needle. It was really changed the way I practice. One was learning how to manipulate joints, really changed the way I practice. One was embracing the idea that therapeutic alliance skills and my relationship. Now I'm in Boulder. Like, there are a lot of really skilled clinicians in Boulder, Colorado, that are better than I, you know, maybe at manual therapy. But I always wondered, like, why are people coming to see me? Why is my practice so successful? And when I learned that it wasn't just my technical skills and my manual therapy skills, but it was my relationship with them and how I connected with them and who I was as a person. I was like, wow, that's amazing. Like, this makes so much sense. And so when I took, you know, Howard and Alan's course, right away it clicked. I was like, there's no question, this is the missing piece for me. And so I had this really fast shift in my belief, even though it took a little while for me to roll out, get confident with some of the strategies. Um, just there was no question, and so I just dove in super deep, different from a lot of our colleagues, right, who enter this from like the explain pain neuroscience education world, which is also super important. But as you and I know, it's really just the foundation. It's just the starting point for this much larger ecosystem of interventions, right?
Yeah. Yeah, absolutely. Yeah. So you've been teaching, and just brief about teaching this to other health professionals and physical therapists. What's been the response, would you say, having taught, you know, some of these classes with Dr. Schubiner?
Oh, there's been a wide range. I mean, I had a clinician who took our course, the first course we took, and like what it's been now 4 or 5 years later, just it told me how angry he was at some of the stuff I was sharing, busting myths around things we now know through the research to not be true. I don't remember if it was core stability or upper lower cross syndrome, or I don't know, you know, backward sacral torsions. I don't know. I was just going through my part of the course where I was addressing those things, and he was really angry. And he's one of now the most skilled clinicians in doing this work, but he acknowledged that at the time it was really hard for him. And so we give that caveat up front, that this is such a radical paradigm shift. You know, it still is for me day to day, 10 years on,
Yeah.
much less for a clinician that's just learning it. And these are, by the way, these are clinicians that are already sort of ready enough that they sign up for a continuing
Right.
education course, much less the rest of our colleagues who really are, some even may feel threatened. You know, their
Yeah.
livelihood and their business model their income, how they support their family might even be threatened by this work. And I'm really sensitive to that when I market, knowing that like I really want this person who I know would be great at this to come take this course, but it's going to blow up their world, you know.
Yeah, you're right. It blew up my world. But I think, there's room for everybody to take what they can into their work, and the more you see it, like you said, on a personal level, like you said, you can't ignore it. And it's interesting, you said you started to notice this back and when you were working with people, and I did too. And I think it was in the early 2000s, working with a lot of workers' comp. I just started to go, this isn't making sense. Something's not right here. Like you said, I remember you talk about the, therapeutic alliance and relationship work. When I first came out of PT school, I was working in this one clinic, and there was this one PT, and everybody loved him. Everybody wanted to see this guy. He was like the top guy in the area. And I said, oh yeah, I'm going to work for him, see what he's all about. Well, just like you said, it was not about his manual therapy skills. I was like, wow, he's barely doing anything. What is he doing? This is so, simple stuff. But he got the best results. And it was just like you said, it was his way of relating to the patients that was just exceptional and drove his outcomes, to be so well. So it's interesting you said that.
Yeah, it took a lot of, Howard, Dr. Schubiner is the Morpheus to my Neo, right? It's talking about the Matrix, and we share that when we teach that clip of the red pill and the blue pill. And I need a lot of permission, and I find myself now giving that to other clinicians. It's sort of a radical permission to get out of your silo and take some chances and make some mistakes. But really, you see as you do that how rich and rewarding the work is, because the outcomes are just amazing.
Yeah, the outcomes are amazing and so rewarding, right? Personally, and obviously for the patient who's getting better. But when you see it working, it's just like, oh my gosh, I'm like a little kid in a candy shop some days going, this is the biggest thing missed in medicine, right? And it's like such a secret that nobody knows about, and the brain's the final frontier, you could say, in this world, I think. So yeah, that's awesome. So maybe share a little more with how you work now. Like let's talk about the shift, okay? Because I think even the audience, people are trying to get better, and other practitioners out there, what that's like for you now, when you're working with people. How's it different?
Yeah, I mean, more and more my practice is people coming to see me for this reason, right? They know what I do. They've been told by other people what I do. So it's gotten a bit easier in that way. It's not like a hard sell where I'm having to like really work to help people shift their belief. And I think it's important to, more and more I recognize and appreciate that this isn't just my opinion. This isn't just your opinion, right? And so people talk about buy-in, but I'm like, we have 30 years of science that all pain, regardless of the cause, presents through a biopsychosocial lens. Whether you had surgery or an injury, or you've been dealing with pain for 20 years and your body's fine, all pain is going to present through a biopsychosocial lens. And so we don't have to make it like a dualistic, it's either your body or it's your brain anymore, which is kind of how I learned it originally.
Right.
And that's made it, I would say, a little bit more complex in a way, right? It's not as simple. It's more of a continuum. And there's, for you and I as physical therapists, there's a little bit more gray around, but there's stuff in the body that we still maybe want to talk about, even if it's just deconditioning or adaptive change. And how do we do that without sending the wrong message that there's something wrong with the person or something broken or something damaged? How do we do that without increasing fear, reinforcing safety in the process? And so my clinical practice now really is focused on that balancing safety, right? Bringing as much safety, reducing fear as much as I can into the process. Even regardless of whether we're talking about the body, corrective exercise, mobility, stability, or we're talking about emotions, feelings that are associated with the person's primary relationship or something stressful that's going on in their life, or we're talking about thought patterns or them being really hard on themselves with their work. Bringing all these things together as a clinician feels a little bit more complex at first. but really you're just expanding the number of variables that you're considering to distill it down to the most important variables that are going to help that person the most. And so everyone talks about, right, in our field, everyone's like, pain is so complex. It's this complex experience. And I've taken continuing education courses and been in conferences where they use the word complex like 100 times in an hour. I'm like, how is that helpful to any clinician or to any patient?
Yeah.
Right?
You're basically sending that message and putting it into someone's brain, which makes them more confused.
For sure. And it's just implanting more fear that, oh, now this is even more complex than it used to be. And wow, now I need even more clinicians to help me with this. And that's not true at all. As you know, as clinicians, it's our job to bear witness to someone's story and their suffering first and foremost. And then it's our second task is to collaborate with them to really understand while pain is complex as a human experience, because we're all different and because we're complex people, the solution, right, and the strategies that help people unlearn pain or overcome pain can be quite simple. And we collaborate with people to find the right mix of things. And it doesn't have to be complex. So I don't know, that was a long-winded way of saying, what does my practice look like? It's still a mix of mind and body, right? Because you can't separate them.
Yeah.
But how can we talk about and treat and address the stuff that's going on in the body without increasing fear? And that's the dance that I'm doing every day with every person. And it's a little bit different with every person. Some people, just had a client this morning who is sort of a friend, and he's not comfortable talking with me about stuff going on in his marriage because we're friends. I said, hey, listen, even if you just come in and for 30 minutes, I evaluate you and, look at your body through my clinician lens and give you some clarity on, whether there's something wrong with your hip, whether there's something wrong with your back or not. And then you can go do the other stuff with your therapist. That might be all this athlete needs to be able to move forward, is to rule out the body, maybe get a little guidance about graded exposure process of getting back into moving again. With someone else, I'm leading a time traveler visualization where I'm supporting people in going back to a time when something happened to them that they need to right or wrong, and they need to go back and need to express anger and do something that they couldn't do then and support themselves. And this is more of a psychological visualization that allows them to welcome their emotions and honor their emotions and make the space to express their emotions, not just regulate them or bury them, right?
Yeah.
Those might be back-to-back clients. So at some point, I feel like an ADHD kid, which keeps me excited. I love it, but I can see how it would be overwhelming.
Right? Yeah, no, you have it's a broad range where you could go, like you said, and I've seen that too, where it's like people ask, well, what are we going to do? And I go, well, I want to know about you, because like you said, you can go here, here, here. And I think that's part of the intrigue and the learning that I'm still learning too, is what's the most efficient way or the best way to work with this person, right? Because there could be a lot of variables happening, right? And you're like, okay, but I think you're right. I think you're dead on when you say, okay, it's all about that fear and the safety and reducing the danger in that person's brain and body. And that danger could be emotions, danger could be movement, danger could be thoughts, right? People, places. So if you come from that, like you said, that foundation, and then work off what is that for that person, or memories or childhood events, yeah, you can go a lot of places, can't you? To try to work with that.
A lot of places. Yeah, you never know. And I love when we teach, I talk about, deja vu is when like you've been there before, it's familiar. Like this feels like deja vu. I like the term vujade, which is every patient is a new start. Every patient is a new experience. I try to encourage clinicians to not make rules, but to just almost be surprised about what comes out, which is scary when you're used to sort of not a rule-based, but like a clinical prediction-based process where you're staying open to the idea of what might happen without knowing the answer already. Like, oh, this is just another patellofemoral pain patient. And what do I do? Oh, I strengthen the hamstrings and get the glutes firing and stretch this. And that's not how we practice anymore, right? And the realization that you and I were probably taught in school that we have all the answers. We're in charge, right? It's paternalistic, and the person's coming to see us because we know what's wrong. When really the reality is the patient has all the answers, and our job is to get them out, get that out of them, and then work with them to try to figure out the fact that they also have all the solutions.
Yeah.
And like that's terrifying as a physical therapist that was trained in the paternalistic model, but it's also so liberating, isn't it?
Very much
To
so.
be
Yeah.
like,
My
have
listening
all the
skills
answers.
have gone way through the roof by listening and just really being that and picking up on things that I would normally not even know or just not even be thinking about. Right. It's so important because you can learn about that person. And you're totally right. It's the person. It's them that's leading us versus us leading them a lot of times.
Yeah, and then they have autonomy, which also we know from the research, right, leads to better outcomes when people feel they
Yeah.
have autonomy. That variable alone provides so much relief.
Yeah. Yeah. Autonomy, self-efficacy. There's so many different pieces here. Yeah. So that's wonderful. So you've been really, dove into this world. You've been teaching some of this stuff now and you're practicing as a clinician. And maybe share with the audience like a success story, if you can think of somebody you work with this model in the way we're just talking about, just to highlight how this works for somebody in a recovery.
Oh man,
Put
you're
you on
gonna
the
make
spot
me.
here. I know.
No, this is okay. Do you want to start with a story and then I'll think about a story?
Yeah, yeah,
I have
sure. I
so many.
mean, there's so many stories. I just put a couple up on my YouTube. Um, I'll talk about the last story because I just put it up. It's fresh of a person I work with who, we got to work with over a length of period of time. It wasn't a quick recovery, but she had pretty severe anxiety and had things happen from childhood. But she had long COVID symptoms, and she had at the time hadn't been fully checked out, but she did once we started working together. And we deduced from the evidence, like you said, it's not my opinion, but from everything she told me about her as a person from the biopsychosocial model, I said, look, this is anxiety. And I was, to get to the point where, like you said, the confidence to make that diagnosis, I wouldn't call it a diagnosis because I'm a coach, but to see, hey, I think this is what this is. Like she said, it was to hear that was like a relief to her. And it did make sense to her because of her history and all the evidence. But, like you said, knowledge wasn't the cure for her. She needed more. So we just worked together over a period of time to reduce that fear, okay, and return to the things she wanted to do. And there were lots of ups and downs. There were lots of ups and downs. There were lots of different symptoms. She had about 25 different symptom imperatives in her body during that time. It took us over a year for her. So it was a long-term case, but she prevailed and she did eventually, get back to everything. She's a psychologist and now she's doing this work, interesting enough, with people because it's interesting. She was working in pain as a psychologist in pain psychology. She was doing this, but it was a totally different model in the UK.
CBT, or of a
Yeah,
CBT
CBT
model.
and stuff. So she not only recovered, and I said, my God, you're going to be the best practitioner because you lived it.
Yeah.
But now she's starting her own practice. So it's so awesome to see her, where she was and where she is now. Yeah.
Amazing. Amazing. Okay. Well, that made me think of a couple stories. So, one client, which is more of a longer case, had a spinal fusion and then had an infection and had a revision of her spinal fusion. And it's a great example of someone that was in the traditional PT model and was getting the right treatments, but was actually going the wrong direction. Her pain was getting worse, and she was disabled. Basically, couldn't sit in a car, had to lie in the back seat, couldn't travel. And so her physical therapist like just knew that there was something else that she needed. So I started seeing her. And over the course of about a year and reducing fear and a combination of working on the body, because she was obviously very deconditioned and had a lot of adaptive change. Like, for example, the skin on her back around the surgery site was like glued to her tissue underneath
Wow.
fascially, right? And
Wow.
so you can't even like pick the skin up. There's no suppleness there, and there's a long scar. And so it's a combination of body work. And at the time, I ran my business in this CrossFit gym. And it was a very weird setting because people walk through this metal door into this 10,000 square foot warehouse, and there's all this activity and action going on, people working out, they're real strong, they're sweaty. And she's like coming into my setting, right? Which is, you'd think would be kind of intimidating. But as we got to know each other and she trusted me, every time she'd come in, she'd say, I think I want to try that. Like she'd see someone doing something, or I think I want to try that. And so we'd figure out a way to scale it, make it accessible, make it fun. We'd
Yeah.
laugh, we'd make it playful. And she got so excited about it that over the course of about 6 months, we just started adding things back into her life. And as we did that, we would talk about these other sort of family and life stresses that were going on for her with her relationship, with her siblings, with her parents. We're connecting about all these things while she's working out.
Yeah.
And that led into this whole other process that wasn't focused on her body at all, about stuff that even started in childhood.
Mm-hmm.
And I can't do this for everybody. She really trusted me. We had great rapport. And now she can do anything she wants. She's gone from being totally disabled to running and hiking and lifting weights. And she goes to the park and does all these movements that she's learned. She throws the Frisbee. She's not limited physically at all.
Yeah.
So now when we meet, we often meet in the park once a month and we just talk about her stuff that's going on in her life.
Right.
And I'm like,
Isn't it amazing that now she's fully functional, she's doing everything, and now it's just managing stress and
yeah.
yeah, amazing.
Yeah, and so I'm like, I feel like I'm an extended member of her family, but I'm impartial, I'm independent, and so she can share things with me that she wouldn't share with her siblings, let's say. And so that's been really fun to see how that relationship has evolved. But if I may, I want to share one other story that's like on the
Sure.
opposite end of the continuum, because as you know, here in Boulder we have a lot of athletes, so I work with a lot of athletes, and when I teach, I'm really clear that acute pain does not equal an injury. And in the research, you see this. Acute pain is defined as tissue damage or something that got injured, and that's not true. Acute pain is pain that just started. It's new pain,
Right.
but it doesn't presuppose a mechanism. And we need to be really careful about that, because I have a lot of athletes that come in to see me, when I'm thinking of specifically that was training for a marathon in the mountains, altitude, hard race. I'd done all the training, did fine. And then, like a lot of athletes, about 10 days before the race, when she was tapering, she started to have pain. And people don't know what a taper is. It's when the training volume comes down and you're sort of letting your body recover to get ready to perform on race day. And naturally, there are a lot of thoughts and fears and anxieties and what ifs and expectations and pressure and urgency, right? All that comes up for athletes because there's more spaciousness. They're not exercising as much to distract themselves. And in this person's case, their family was coming to watch and they didn't think they'd done enough training and they were being hard on themselves. And there was a lot of fear about what if this, what if that, the natural anxieties that come up for any athlete.
Right.
And this was a calf and foot pain situation. And the easy answer would be, well, duh, you just had your biggest 2 training weeks. You ran 20 miles and then 22 miles. It must be an overuse, overtraining, overload problem, right? But on exam, that wasn't how it presented at all. And in the presence of these other stressors that she shared with me during her history, it became very clear that, as you said before, this has an anxiety component to it. This has a psychological and social component. It's the pressure she's putting on herself. It's the social part of her family being there that adds to that.
Yeah.
And when she understood that her body was okay, and we addressed some of these other fears, and surprising to her, I said, there's nothing wrong with your body's fine, and gave her permission to go race. She felt 100 times more confident. She wasn't fully sold because she hadn't seen that she could go race yet, but that's what she did. She went to the race, she traveled, she had an amazing race, and there was no pain. And she texted me afterwards and she was shocked. She couldn't believe that she could go from having calf and heel pain, plantar fasciitis. You think that should take months to recover, right?
Yeah.
But she felt better within a few days and she ran a marathon as though nothing had ever happened. So the more you see this, the more you're like, that's amazing that we can interrupt this earlier in the process before it tips over into chronicity and even have more of an impact on people. So we don't have to wait 3 months, 6 months, a year later to be interrupting this cycle for people.
Yeah, that's amazing. Just brought to mind, actually, I had a similar personal story. Years ago, I was running the New York City Marathon and I did the exact same thing. It was in the slowdown taper period. My calf apparently blew up, you know. And at the time, I didn't know about this is pre-Sarno, but I was my PT, who again the superstar PT in the place I worked, who didn't really have great manual therapy skills, but seemed to fix everybody. What did he do? And I, in reflection, yeah, he did some manual therapy, but he totally reassured me that you can do this. You're going to be fine. I don't, there's nothing really, no, you didn't tear anything, you know, same thing. And sure enough, I ran the race and zero pain. So it's interesting you said that story. But I want to highlight the part that I think gets missed in medicine is that psychosocial piece that, and fair enough that people don't believe or think that that piece has the power to cause these symptoms, you know, in our bodies. We think, oh yeah, stress could maybe, it might affect it a little bit. But to think that that could be a primary driver of somebody's symptoms, especially in an acute stage of pain, it's hard for people to buy into that, I think, at some level.
Yeah,
What do you
it's
think?
no, it's very, very hard for people to buy into that, and especially with acute pain, because even in the world you and I live in, that's not really talked about that much. Even though we see it all the time, you know, I mean, we see people come out of hip replacement surgery. Some people day one have no pain and they're so thrilled that they did it and they're walking and they're up. Someone else has pain that goes on for 6 weeks. It's the same surgery, but the outcome is totally different. And why is that? And it's usually because of these psychosocial factors, the fears, the stories they've heard from friends going into the surgery, their trust with the physician, their relationship with the PT afterwards, the support they have from their partner at home, right? All of these things matter when it comes to the outcome from even a surgery, even a real injury.
Yeah, absolutely. And that's the part that blows me away every day, how I always say the power of the brain. And that's something that's so discounted, right? In medicine, really. It's an aside. It's like the last thing you'd look at if nothing else works, right? It's not something you ask about usually up front. And I think that's what's so cool about the work we're doing now is that we include that. You know, I think of a patient too who had a sciatica pain in Europe. This was a couple of years ago, and she had started very benignly at work, just sitting in her chair like she does every day for the last 15 years. And she had gone on to have surgery on her piriformis in the US. She flew to New York City. She had a surgery, was unsuccessful. She came back, you know, treatment's not better. She reached out to me. We talked. One of my first questions was, you know, around that time, was there what kind of stress was going on in your life? Was there life change stress? Nobody asked her that question. And it was a powerful question because her father passed away suddenly from a heart attack about 2 months prior. And just as somebody could have asked that question, because there was no history of injury, right? So that's when you start to go, wait, no, like you said, there's no mechanical cause, or that makes sense at least. And I think that's so cool because you can go to the psychosocial side, which does start to make sense when you go, oh yeah, I must have slept wrong, or oh yeah, I turned my head in the car. Well, how many times do you do that, you know, every day?
Yeah, yeah. I was thinking when you were telling that story of a client I saw earlier today, who's had a really hard time transitioning belief wise to the idea that the stresses that are coming up in her life connect to her pain. Even though there's some evidence of that. And of course, we know when people have pain, their logic and their reasoning and their cognitive abilities get smaller because pain is such a distraction. It's so scary at a primal level. So it's really difficult to make that connection in the moment, right? When you're in pain, the first thing you think isn't, oh, I wonder, you know, if something happened stressful for me today, or
Right.
last year, maybe this is an anniversary of like someone important in my life passing away. Like that's not where you go.
No, no.
So, so today we're talking, and um, I asked her that similar question after she said something like, well, maybe it was, you know, maybe it was this thing I did a week ago. You know, and I'm like shaking my head. No.
You're becoming Dr. Sarno now. You're just,
You start making up
yeah.
when people start making up stories about maybe it was that thing that I did. It could have been that. There's like such a reaching for a physical explanation, which makes total sense because this is how we were all raised and this is what we all were learned about pain. But as soon as I asked her that question, she instantly had an answer for what was going on when my pain started 3 days ago. Oh, this and this and this. And then what was going on when it started to feel better 2 days later? Oh yeah, directly correlated with this.
Yeah.
And she may have never done that otherwise because no one had ever given her permission, as you said, or asked her. And even then, she still had a little bit of dissonance about, I just have such a hard time believing that this pain that feels so real in my body, because I'll say it again and again with my patients, all pain is real. It's the same pain. There's no difference.
Yeah.
She had such a hard time believing that that could be triggered by her relationship with her partner and her adopted daughter, and how when those things resolved, her pain started to feel better. Like when you see it, it's like so clear and obvious.
Yeah.
But I totally get that it's difficult to get out from underneath this old belief system.
It's hard. And even when people share with me a recent story as we're working through this, and I can say, hey, wait, look, can't you see how this stress here kicked up your symptoms, like you said? And then as you relax about it, it came down. It's a really direct correlation. And they go, oh, yeah, there's still this, it's still not a complete connection, right? It's like we can actually see that actually happening, and we can still, because of the old belief system and what we've learned, it's hard to fully adopt that, I think. So it's an interesting process.
Yeah, how do you, Jim, how do you explain to people like this idea that pain is a protector, right? And in whatever case, in this case, pain is coming on to protect my client from the emotions that may be more aversive or bigger or scarier in the moment. How do you explain that phenomenon to people that, you know, your brain's just trying to protect you, but it doesn't speak English, so it's using this pain to tell you that something emotionally isn't safe?
Yeah.
Do you have a favorite psycho ed strategy?
I don't know if I have a favorite. I usually about that point have their history. So I have some evidence of times where that's happened, or I can look back and say, hey, based on, we know your emotional style from growing up was one that maybe you suppressed your emotions. You didn't have the ability to express yourself, or you weren't allowed, or it was seen as being bad. Sometimes, like, for example, with anger, that's a common one. I'll ask them a simple question. I said, do you have tendency to avoid conflict? Do you not like conflict? And that's a good question, because somebody will say, no, I hate conflict. I really don't like it. And then I say, just look at those two words, avoid and conflict. Avoid is fear, right? And conflict is representing the emotion of anger. So if you avoid that situation, you might get anxious and fearful, and right, you might feel that coming up in your body as a clue that you don't want to do that. So I might look at that, or I might say, hey, what happened there in that situation? Like, is there another time in your life you can remember where you were stressed about something and you noticed something in your body? And so finding that connection somewhere, I'll ask them to look during your day. Can you see if you can see a time when you're stressed during the day, notice an emotion coming up, and you also notice the symptom popping up? So the more times you can make that connection clearly for them, I think it's helpful. So yeah, there's different ways, I think, but yeah, in terms of the danger, I just explain it to them in that way, that look, your body, when that you don't want to be in that conflict, let's say, kicks up that anxiety, which we know can kick up symptoms in your body. And then sometimes I'll do some research. I'll explain some of the science behind this. It can be helpful for some people to understand it. But it is a big time shift to move thinking that this could be an emotion popping up in yourself, not a physical symptom.
Don't you feel people prefer, like, wouldn't a lot of my clients, if I surveyed them, would probably prefer that there was something wrong with the body than something tied to their childhood that was around, like, I'm not lovable or I'm not loved. Like, it makes sense, right, when you say it that way. Like, why would the brain choose pain over these other big emotions?
Yeah.
And I think that's what makes, I think, the work really hard to do for some people, because it is so emotionally
So
challenging.
physical, the symptom's so physical, and so the emotions is buried there, right? So some people don't even feel emotional at all, like absolutely no emotion. So I have had people say, I don't get angry. No, Jim, I don't get angry. I go, what about that migraine that's screaming in your head? What is that? But there's a disconnect from that, because you're like, that doesn't add up.
Yeah, well, and anger feels destructive, right? Anger is scary, it's aversive, and a lot of us learned that anger wasn't okay, it wasn't safe, it wasn't allowed. We had to regulate our anger. And so, of course, you're not going to want to look at anger because it's potentially destructive. And I love when people say that I don't have anger. I'm like, uh-huh, yeah.
You
Yeah,
must be
yeah,
the
me
perfect
neither.
human. Yeah, right.
Yeah, yeah.
Yeah,
Uh, it's one of my favorite emotions. I love supporting people in processing anger. I think one of my big takeaways that I kind of knew, but like it wasn't this explicit from the last time we taught this course, Howard and I, is that the goal is not to regulate our emotions, right? I think a lot of us learned that regulating our emotions was the way to be. And I grew up this way. I was the golden child, the easy kid. I took care of other people. I kept my emotions to myself. And and turns out that's not so helpful. So the idea that expressing emotions is actually the healthier strategy is kind of radical, especially given the fact that we don't really have a lot of support for that in our society. And so I get really excited now at the prospect of giving people permission to be angry or
yes.
permission to hate their kids or permission, whatever the thing is, like it all belongs. We welcome it all. And that is such a fun, for me, it's fun part of the process, personally and professionally.
Yeah, I totally agree with you. It's funny that you share that because anger was for me personally a very difficult emotion growing up, and I had really little access to it, never expressed it. And now, like you said, it's one of my favorite emotions. So you can go from like having no connection to it to saying, man, anger is awesome if you know how to work with it. And when you see people open up to it and express and use it for empowerment, and I always say use anger for action, you can use it as a fuel source to go forward against your fear. I'm like, it is such a powerful emotion when used in the right way, isn't it? And so it's just cool to see people get access to it, express it. And I have so many stories that swirl in my head of people who just are that perfect Sarno patient with all the personality traits, and they're such a good person, such a nice person, and just don't express it, And I was thinking of one person I work with whose family is she's like they're lunatics. She's like they're absolute lunatics. They yell at each other, they scream, they get their anger, and then they go have a glass of wine afterwards and they're fine. And she's the one just absorbing it all. And she's got the chronic fatigue and the chronic pains. And it's
Oh,
tough. And I get it. And it's really hard because that's not her natural style. She's a sensitive person and she doesn't like, I get it. I don't think it's healthy what they're doing, but at some level, they're expressing it. So anger is such an interesting emotion to work with, I think. Yeah.
yeah. Did you happen to watch Wimbledon, the men's final yesterday? Do you
I
follow
didn't
tennis at
see it.
all?
No, no, what happened?
Okay. So it was a great match. It went to 5 sets, and it was Djokovic, who's like the veteran, hasn't lost at Wimbledon since he was 10, expert on grass, versus I'm gonna mess his name up, Alcaraz, maybe, young Spanish, 20-year-old, super athletic young guy that's just learning to play on grass. And Djokovic lost for the first time. But in the last set, he was getting frustrated. The momentum kept shifting. He was getting frustrated. He took his racket and broke it on the vertical that holds the net right
Yeah.
by the right by the judge or whatever, the referee. And he actually hurt his wrist a little bit. Like you could see that he tweaked his wrist because he hit the thing so hard. But he was super angry
Yeah.
and he expressed it publicly, which arguably is not the best idea, but brilliantly for the next couple games he actually played better
Yeah.
because he allowed himself to be angry, and that energy actually brought him back to life in the match. Now it didn't last very long, and there's this idea that anger sort of burns dirty if
Yeah.
you're not processing it through to the maybe the guilt and the compassion, the forgiveness and the love on the other side of it, right?
Right. Right.
But um, athletes use anger all the time to fuel those performances. And I thought that was a really interesting example of an attempt to recover from this losing, basically, which
Yeah.
helped for a little. And it's possible, that he could have pulled it off. I don't know.
Yeah, no, I mean, people can activate anger, right, and channel it. Can do. I always think of Michael Jordan, watching his documentary and some other people out there, and the ones who can't control it very well. I feel like it does get the better. I mean, who was the other tennis player where I feel like he might have had some TMS? The British guy, he had a bunch of hip surgeries and stuff. Do you know back surgeries? What was his name? He
I'm
was a
not going to remember.
anyhow. I felt like he kind of didn't work well with anger. He would just get angry and kind of look like he was mad at himself, and like he kind of was hitting himself, beating himself up a lot. And I wish I could remember his name, but it seemed like that might have channeled into his body in some negative way.
Yeah.
So
You mentioned Michael Jordan. He used to make up things to make him angry so he'd play better, even if he didn't have a reason to be angry, which
right, right. But you're right about that. I do see some people on the flip side. I mean, I don't think it's as often because the TMS person I see typically is more that suppressive, repressive person, but the person who is really angry, they're an angry person and they actually went the other way. So if they like got married and have kids and they go, oh, I better hold, I can't do that anymore. It's not good to get blown up. And then they end up with symptoms in the body. So they go in the other direction. So it's interesting to see. Sometimes I'll see that as well.
yeah. You used the word symptom imperative earlier. You kind of like during your story. I'm assuming maybe your viewers know what symptom imperative is. People can define it differently, but this idea that the symptoms will keep moving around or showing up in a new area to try to continue to get your attention as long as there's fear, the danger alarm is still going off. Is that sort of how you define it for people?
Yeah, absolutely. Or they're not, yeah, not getting to the core emotion, which a lot of times is fear driving that. And sometimes I think like that last case study I put up of Belle, her recovery was such that the fear was so strong that it kept coming out in these different things. And because that was a protective thing, like you said, anxiety, it was a protective measure for her, but she had to learn to disarm that through multiple symptoms. And then as she finally was able to do that, she prevailed and her system relaxed. But it took us literally over 25 symptom imperatives. It was incredible.
That's a lot. And sometimes it even comes back to the original symptom. You're like, oh, we're back here again. Yeah,
Right.
it can be really frustrating.
It can be really
The reason
frustrating.
yeah, the reason I brought that up is because another thing I took away from teaching with Howard, and I always learn from teaching. I'm sure you do too. Like it's I learn as much as sometimes the students that are there. But I always use this Death Star analogy when I'm talking about treating the body or the mind. That in this first Star Wars film, there's this war going on, but when they blow up the Death Star, the war's over basically. So how do we find the Death Star variable, the body or the mind variable to treat to get this person well? And I always sort of, as a clinician, put pressure on myself to say, well, the symptoms keep moving around, so we must not have found the most important variable yet. We must need to go back further, dig deeper, go back and talk about the family of origin. And that can be really stressful for us. And it can put that urgency can come off on the patient, and that's not helpful for them either. So I think while Howard was here, we were playing golf and we were talking about this idea. And Howard makes things very simple, which is one thing I
Yeah.
appreciate about him. And he says he's a very simple person. Well, you could argue that, but
Right. Right.
he shared this idea, which I thought was much more compassionate. This idea, and you referenced this earlier too, that some people just are born with a more sensitive nervous system. And I put myself in that category where I'm more sensitive to things, and I always have been. And when you know that about yourself, and when you can accept that about yourself and see the light and the dark around that personality style, or whatever you'd call it, that style, you can really appreciate the things about that are really important for you in your life. But then understand that you're going to have times when symptoms come on, and that's okay, because they're not dangerous at that point. And so it's like accepting that you're going to have some amount of symptom imperative behavior, that we don't need to go back and process all your trauma and fix all of your emotional wounds, heal those to be able to feel better. And I really liked, for me, it was very reassuring to just accept that we didn't have to like cure everybody 100% so they never have pain again. Because of course,
Right.
pain is part of all of our human experience. What do you think about that idea? Maybe that's already how you thought about it, but it was good for me. It was like a click.
Yeah, I like that because I feel like for me and for the client, the patient is they're like, okay, what am I missing? What's the needle in the haystack? There's got to be something here that back in my past that I need to find or work on, and I find that really challenging to find that, per se, and it adds more stress. mean, I like to think, I guess, in terms of themes and like, okay, what's the theme that's come out of childhood that you present with now, through your personality or
Mhm.
what happened to you. And I think going back can be helpful in certain ways. And I do that with people to go through and process, like you had said, some anger and things like that. But I think, yeah, more that, hey, our systems marry innately, or we be genetically, we're sensitive, and I'm the same way. And I still get stuff, right? But stuff doesn't last because I think, like you said, I understand it, that is not dangerous. And I think that's the key take home here is that, look, we're humans, we're going to have things coming up, the neural pathways, activate in certain ways for people, and they get certain things, sometimes physical and not always just purely emotional. And that's okay. I get people saying, well, I want this, I want to feel this as an emotion. I don't want to feel this as a back pain. I said, well, you work towards that, but don't put the pressure on yourself. Just know that that's probably not an injury, and it's going to go away. And you can figure out maybe what emotion it is. But I think sometimes it adds so much more pressure. I don't know what you think about it, but I think it adds more pressure at times on me and the client.
Yeah, I always have this orientation towards I want to make meaning, I want to understand, I want to know the truth, I want to know, you know, uh, to get to the core of why this is happening, and that's not always helpful
And
for
I think
people.
even if you know the core, like, and maybe I think Howard had said this to me at one point too, like people know their trauma. Some people, they know their PTSD. Just because you know what it is, and I always tell this to patients, I'm like, just because you know what it is doesn't mean it's going to go away, right? So it's going to reflect in your present, but you can work with that. And I really like to go back when we talk about the past. Just as an aside here, I really like to really make it safe. And I go, look, everything you're talking about is a memory now. Like it's not dangerous. As much as you can conceptualize that and really embody that whatever's in the past is not dangerous. And if that's coming up now, it's totally not dangerous. And you can't stop that. It's your limbic brain. It's impossible for you to stop it. So let's just learn to work with it, if it comes in this good way. So
Yeah,
yeah, it's challenging though, isn't it?
it is. And of course, the other opportunity there, right, is that memories degrade by definition. Like our memories of what happened 20 years ago are not accurate or
Yeah.
complete. So the opportunity using memory reconsolidation is to go back and visualize or implant a new memory where the person is more empowered to show up, or
Yeah.
they can go back and take care of themselves in a way that they couldn't at that time. And I really think that part of the process is beautiful when people are willing to go there. It's really healing.
Yeah, I agree. And then I can bring that forward into the present with that new
Yeah.
empowerment. And I think, I mean, I know we could probably talk all day about this, but I think empowerment is a really key piece that I see people over time to build that in people, right? The confidence, self-efficacy, empowerment, strength, tapping into anger. I really feel like that's a critical piece for a lot of people that have been victims to things or feel ashamed about a lot of things. And I know
Yeah,
Howard has really said that to me too. He feels like that's an important piece as well in the past.
it's that and the sort of self-love and self-compassion. I feel like if more of us could turn that on ourselves, the way
Yeah.
we can give it to other people, that's also such an important missing variable so much of the time. But like as a physical therapist, the barrier to getting there is so often the body and these ideas about movement and how the body works. And I think that's where we're placed really well. And sometimes we don't even get to those things because I don't know about you, but some people have they've done all the things. They've seen the Pain Psychology Center. They've read Unlearn Your Pain. They've seen the documentaries. They've seen clinicians and talked about this. But there's when you really remediate and go back to the basics of what got missed along the way. Like, why are you working so hard? And all that. Like, you could teach this, right? You know so much about this now. You could teach this. What is missing? And oftentimes we come back to something along the way, it didn't get clarified about the body itself or about movement, or there's some fear in there that's still hanging them up around something with their body. And I think it takes a special physical therapist to be able to address that and address that fear head on, in a way that not a lot of other clinicians can. Do you find yourself doing that with your clients? Like, just like, let's go back to the body and talk about the body, because people want to talk, they want to know that you're considering it and looking at it, and it's not just a brain, right?
Yeah, no, I always start with the body, always,
Yeah.
and then go to other stuff. But I always come back to it, and I have to because there's symptoms going on that people are always asking me about, and things popping up, and we're always trying to address it. So yeah, I think the body is important. I think for me now, because I do all my work on Zoom, I'm not in person, where I know some of your work is probably is in Zoom and in person. Is I do coach people on getting back, but it's really about exposure, graded exposure, in a more general way. And then I do address particular things if they come up, about some of the physical aspects. But I really do, yeah, have to reassure the person. I do show studies. I like have like a whole catalog of things where I'm like, oh yeah, what about? I go, hey, check this out here about your knee, and so that helps people too to say, hey, it's not just me, my opinion. So I try to instill the confidence in people through evidence-based stuff. And then, but
Yeah.
it is about mind body, isn't it? It's not just the brain, it is also the body.
Yeah, for sure. I think I've tried to get really creative on Zoom, evaluating people from a distance, asking them to do movements and certain things and try things and show me, so I can really give them confidence that it's not that your quad is short or your hamstring is short or this is weak or that is weak or this isn't firing. Using like real time movement, I'm basically asking them to do some of the tests that I would want to do in the clinic.
Yeah.
And you can really do a lot of reassurance when another PT or another clinician has said you're in pain because your abs are weak or your glutes aren't firing, or there's some myth that they're really hung up on that's really sticky,
Right.
or maybe your meniscus is degenerative. Well, how does your squat look? Can you squat all the way to the bottom without pain? Is your knee catching and locking and giving out? No. Like, sometimes it doesn't take much
No.
to show people that those things maybe aren't true, or they aren't true anymore.
Yeah. I agree 100%. Yeah. You can use that body in that way. And I've done that many a time with people in the call. We get them in standing or sitting or moving. I had a lady, never forget it. She's like, oh, I can't put that, I've been able to use my arm to lift the trash up to put in the garbage can. I'm like, come on, that's a bunch of crap. Let's go do it right now. She took her phone out there. I said, all right, let me see the trash. I'm like, come on, that's like nothing. That's like what, 2 pounds? And so I had her do it and I watched her and she did it no problem. She did it really fast because she was really scared. And I said, oh my God, you did that amazing. And it's stuff like that where you just challenge the person right on the spot. And I've done it. I had a lady with sciatica pain screaming down her legs. She's like, I can't stand for more than a minute. I said, well, let's stand up right now and let's work with this. And I do some reassurance, calming, and just breathing. And sure enough, the pain actually went down after about 2 minutes because she stood through the pain as I reassured her. The danger signal came down, and and it took us actually more than that to get better, right? But that was her starting point so that she could stand and go back. So I love it when I can do things in person. I've had people driving the car and I'm on the phone there talking to them. I don't do it all the time, but I love when I get the chance to do that, even through Zoom.
Yeah, it's brilliant. It's amazing. Do you still bring a lot of specific PT movement, corrective exercise, prescriptive type exercises into your practice with people, or do you find that increases fear?
Yeah, I actually don't. I would say now but I say the large majority of people I see are chronic. Um, so I really don't. I might address a couple of things, but primarily no, because I think it does introduce more fear for these people. And
Yeah.
they've already done that. Most of the people I get their history have done all those things. So, but I'm getting more real chronic people. I don't know if are you getting a mix of acute, subacute, chronic in your practice?
I have a mix of like the
Yeah.
pain just started today or yesterday,
Yeah.
or subacute or chronic. So I spend a lot of time in that gray area, where there's room to do both. But the hardest thing about that is the confusion, the dissonance it creates. Because if we want to be able to tell people there's nothing wrong with their body when we can, and oftentimes we can,
Yeah.
but either the person doesn't fully believe that yet, or we don't have enough evidence yet. You're kind of left to do both and doing that with I don't know what's the right word, like fidelity, to this larger paradigm shift, I think can be really challenging because you run the risk of sending the wrong message. But that said, some of those things are really helpful. And again, it's the same exercise. For one person, it increases fear and they get worse. And that's kind of cool because that's even evidence, right? For
Right.
someone else, they do the exercise and they feel better. And you're like, that's amazing, right?
Yeah.
It made you feel safe.
Made you feel safe. I think that's it. Maybe we can end that note. I think the more I did this work, the more I thought about all the myriad of treatments out there that appear to be doing this and that. I really think a lot of it's about creating safety in that nervous system and brain for the person, and that they trust in that. They trust in their person. They think that this is good for them, and it disarms them, right? Because I don't think there's like so many different ways we can do all this thing. We have one system, right? So, like you said, one thing could be great for one person and be a disaster for another person. So it's just figuring out how we can create that safety. Well, that's awesome, Charlie. I know we could talk for hours on this, and I really wanted to bring you on because I think you add a lot of depth to what this world and in the PT world especially, and that you're out there doing this.
We do that. I think we do that together. Yeah, it's a good conversation.
Yeah, it was awesome, and I think the listeners will gain a lot from this. Is picking up little tidbits. How can someone find out more about you if they're interested in your work, or they maybe even want to work with you at some capacity?
Yeah, thanks for asking. My website is mperformance.com, the letter M, performance.com. That's my clinical practice, which is a mix of coaching and in-person physical therapy. I'm also on YouTube. I think it's Merrill Performance Boulder, my last name, Merrill Performance Boulder. I haven't really been putting a lot of time into that, but I think you're going to inspire me to get back to doing that again. But so mostly I'm on Instagram, which is at Charlie Merrill, just my name. I always appreciate people following me there, and that's where I'm putting most of my energy right now, in little chunks to get this stuff out there. I'm building a course right now specifically for athletes, using this model, but again, with this balance of body and mind, and bringing a lot of stories from professional sports and speaking specifically to, a more athlete-minded person. And that audience really isn't getting a lot of the support they need. So they get stuck with these injuries that stick around that they can't figure out. So I'm building this course as a 6-week experiential, asynchronous, but group synchronous sort of journey. Like there's like a story, it's like a storyline built in. So I'm excited about that. I'm going to launch that probably next month. So
Awesome. That's great. And then send me all those links. I'll put them on the YouTube liner so people want to learn more about what you're doing and stuff. I think it's awesome. We need more people, right? We need more PTs. We need more people in general doing this work. So I'm super stoked that you're doing it, and spreading the good word, as we would say.
You too. Yeah, I appreciate having you on the team. I feel like we should put together a list of clinicians so that people have an easier time accessing those of us that do this work, because I think they're out there and maybe it's just not organized yet in a way that people can see. I need someone in New Jersey, or I need someone in Nashville. Having that list would be cool. So
yeah, well, we can talk about it off air. I think that would be good to do, especially in our world, because we're out here doing this work and trying to inspire other people. So awesome to talk today, Charlie. I'll talk to you, just stay on the line here when we go off and chat before we leave, but really happy you came on, and thanks for coming on and sharing your knowledge and insight and stories.
Thanks for hosting. Thanks for making the time in the space, and yeah, connecting sort of face to face is fantastic. Let's do it again.
Let's do it again. Okay. We'll see you next time.
Right.